Hello, everyone, and welcome to today's Fistula Care Plus Fistula Community of Practice webinar. My name is Vandana Tripathi, and I am the Deputy Director of FC Plus. And these webinars are part of a series that we host from time to time to share up-to-date recent knowledge, learning from our project, as well as our partners. We share these with the fistula community of practice. That is, folks who are interested in fistula prevention, treatment, and related maternal health issues. I want to point out that we archive all of our webinars, so the slides, the audio are up at the fistulacare.org website, and we'll be putting the archive from today's webinar up very shortly as well, so you can always find resources there. We also encourage you to follow us at Fistula Care on Twitter. Before we get into the topic of today's webinar, I want to give you a bit of an overview on the Fistula Care Plus project. We are a 5-year USAID-funded initiative to strengthen health system capacity for fistula prevention, detection, treatment, and reintegration of women who've had the condition. Through this project and predecessor projects with USAID funding, we've supported over 50,000 surgical fistula repairs and trained more than 28,700 healthcare workers. The Fistula Care Plus project has also supported 980 non-surgical fistula repairs. We currently work in the 6 countries that you see here, and EngenderHealth also addresses fistula with other resources in Guinea. I think most folks are familiar with what genital fistula is, but just to quickly recap, it is an abnormal opening in the upper or lower female genital tract that causes uncontrollable urinary or fecal incontinence. It's hard to get precise estimates for this condition because of its relative rarity and also where many of the affected women live, but it's estimated that between 1 and 2 million women live with fistula, and that there are still thousands of new cases every year. The most well-known cause, of course, is obstetric, and that is fistula that results from inadequate management of prolonged and obstructed labor. But there are other causes such as trauma, and I also want to highlight the increasing importance and problem of iatrogenic fistula. That is fistula caused by surgery, particularly cesarean section. Before we get into the survey that we're here to talk about today, I want to give a little bit of background on why we conducted the survey. And I also want to point out to everyone who's joining us that you can ask questions throughout the webinar by entering it in the question field on your GoToWebinar interface. So please feel free to suggest your questions throughout. At the end, we will take questions, and if we don't have time for all of them, we're going to respond on our website as well. So please feel free to throw out anything you're curious about as we follow this discussion. So prolonged and obstructed labor specifically, is one of the most important direct causes of maternal death. It's estimated that 3 to 6% of deliveries are complicated by obstructed labor. But in addition to the deaths that result from this condition, it's been described as the most disabling of all maternal conditions. The long-term consequences for women include not just genital fistula, but they can include other forms of incontinence and severe nerve injuries as well. It was estimated that in just 49 countries that don't have adequate access to cesarean section, appropriate management of obstructed labor could avert over 1 million DALYs, prevent more than 59,000 obstetric fistulas, and prevent nearly 17,000 maternal deaths. Despite the importance of this condition, there are challenges related to its identification and management. First, there appears to be no consensus on the definition of prolonged and obstructed labor. If we look at literature, we look at regional guidance, WHO guidance, research studies, different definitions are used, and later we'll hear a bit about the most recent 2018 intrapartum care guidance from WHO and see that that doesn't necessarily clarify things either. In addition to lack of precise definitions, we also see a lot of terms that are not well defined that are used, for example, in clinical notes, medical records, to describe indications for cesarean section. So we'll see unsatisfactory progress of labor, delay in labor. These inconsistencies and this lack of clarity are important because they can lead to delays in identification, referral, and management of prolonged or obstructed labor. We also see gaps in the guidelines available to clinicians and the evidence. So much guidance for managing prolonged and obstructed labor and assessing the quality of this management ends at delivery. For example, in criteria-based audit, where the last item may be decided on assisted or operative delivery, with cursory mention only of immediate postpartum operative monitoring. We also see that postpartum care for prolonged and obstructed labor is more frequently referenced in the fistula literature. So for example, WHO's fistula prevention guidelines and the East, Central, and Southern Africa nursing curricula. There's very little guidance for the postpartum period specific to prolonged and obstructed labor. And what exists can actually be inconsistent. So for example, WHO's obstetric fistula manual and midwifery training module on managing prolonged and obstructed labor recommend urinary catheterization for 14 days for all women who've experienced prolonged and obstructed labor. Yet the IMPACT manual, the Integrated Management of Pregnancy and Childbirth, recommends urinary catheterization for 48 hours. So there is conflicting information, conflicting guidance, and definitions that may not be consistent. As a result, we know very little about what skilled birth attendants are actually doing in practice. What is their understanding of this condition? What is their understanding of bladder care during and after birth and management of prolonged and obstructed labor? So to address these gaps, Fistula Care Plus conducted an online global survey of skilled birth attendants who work in low and middle income countries to understand their routine bladder care practices, as well as how they manage prolonged and obstructed labor. So I'm going to turn over now to our fellow panelist, Elly Arnoff, who managed the implementation of this global survey and has just completed the analysis of the results. Elly.
Thank you, Vandana. Hi, everyone. I'm Elly Arnoff, and I'm the Program Associate for Research and Evaluation on the Fistula Care Plus project. As Vandana said, I worked on the survey design, data collection, and analysis, and will be going over the findings from the global survey of skilled birth attendants on intrapartum and postpartum bladder care and management of prolonged and obstructed labor. The survey was designed based on existing labor and delivery clinical guidelines and midwifery training curricula, and with input from fistula specialists. The survey targeted maternity service providers in low and middle income countries as key informants to better understand intrapartum and postpartum clinical practices. Eligibility criteria for participating in the survey included being a skilled birth attendant who has attended a live birth within the past 3 years and practices in a low or middle income country. The survey was administered online using SurveyMonkey in both French and English from May to October 2017 and employed a purposive/snowball sampling approach to recruit new key informants. The analysis was done using Stata and includes descriptive summaries of respondents' characteristics, knowledge, and practices. Chi-square tests of independence were conducted to evaluate variables for significant differences, particularly comparing respondents from Southeast Asia and Africa, from public and non-public facilities, and those working in urban and non-urban areas. Excluding ineligible respondents and those who did not complete the survey, the final analytical sample was 222. A high percentage are from Africa and Southeast Asia and are midwives or nurse midwives, followed by OBGYNs. Nearly all have attended births for at least 2 years, and nearly half for at least 10 years. 83% have at least 2 years of pre-service training, and 33% have at least 4 years. Figure 1 shows the percentage of respondents who report having had in-service training on various topics related to bladder care and management of prolonged obstructed labor. At least 3/4 have had in-service training on partograph, BMONC, and management of prolonged obstructed labor, while less than 2/3 have had training on sepsis, CMONC, intrapartum and postpartum bladder care, and postpartum urinary catheterization. Respondents from Africa were significantly more likely to have had training on management of prolonged obstructed labor, prevention and management of sepsis, and CMONC, and those from public facilities were significantly more likely to have had training on prevention and management of sepsis, while those from urban facilities had more training on CMONC. Nearly half of the respondents report working at referral, regional, academic, or national hospitals, followed by 19% who work at sub-district or district hospitals, and 17% who work at health centers. A large percentage work at public facilities, as well as facilities located in urban areas. And most reported that their facility has the capacity to perform operative delivery. Table 1 illustrates the percentage of respondents reporting facility protocols on intrapartum and postpartum bladder care and management of prolonged obstructed labor. While fewer than half report that their facility has a protocol on intrapartum bladder care, postpartum urinary catheterization, and urinary catheterization following prolonged obstructed labor, slightly over half reported that their facility has a protocol on prevention, identification, and treatment of obstetric fistula. And respondents from Southeast Asia and non-public facilities were significantly more likely to report having protocols on all 4 topics. Almost all respondents report using the Partigraph to monitor labor, with respondents from Africa and non-urban facilities significantly more likely to report always using it. Of those who report using it to monitor labor, 82% report that they always use it to identify and manage prolonged obstructed labor. I want to pause here and note that the reporting of Partigraph usage in the survey is higher than many studies relying on record review and observational data, indicating the possibility of bias in the survey. Nearly 3/4 of the respondents report that a healthy frequency for voiding during labor should be within the recommended range of every 2 to 6 hours. The survey also integrated practices on intrapartum bladder care from existing guidelines and curricula, and Table 2 shows that a large percentage report either always or sometimes performing each of these recommended practices. Nearly 3/4 report that they always ask postpartum patients if they have had any problems with bowel or bladder function, and 2/3 report that they always monitor voiding frequency for postpartum patients during the first 24 hours after delivery. Respondents from Southeast Asia and non-public facilities were significantly more likely to report always asking postpartum patients if they have had bladder or bowel problems and monitoring voiding frequency 24 hours after delivery. Of those who monitor voiding frequency, nearly 3/4 report that they provide urinary catheterization to patients who are not able to pass urine successfully. Of those who perform urinary catheterization, the survey asked after which hour of not voiding do respondents or their team insert a catheter. Figure 2 illustrates the distribution of these responses. Cumulatively, the majority report that they insert a catheter after 2, 4, or 6 hours. In addition to time without voiding, the majority report utilizing additional recommended practices to assess bladder function and if urinary catheterization is needed, with assessing vital signs and checking whether the bladder is palpable as the most widely practiced. The survey also examined postpartum bladder care practices following operative delivery, specifically adherence to existing WHO guidelines. Over 2/3 report always employing the recommended timing of postoperative urinary catheterization for simple cases and those exhibiting a bladder injury. However, only 1/3 report always providing 100 milligrams of nitrofurantoin if the patient is not on antibiotics. Respondents from urban and non-public facilities were significantly more likely to practice these WHO recommendations. The survey examined how respondents identify prolonged obstructed labor, and the responses show variation in how SBAs define prolonged obstructed labor, as indicated by the wide range of responses. Cumulatively, the majority report prolonged obstructed labor as being active labor lasting longer than 8, 12, or 18 hours for prima-para women, and longer than 6, 8, or 12 hours for multi-para women. The median response is 12 hours for prima-para and 8 hours for multi-para women, and the median number of hours were identical across region, facility type, and geography. The survey examined other signs and symptoms respondents used to identify prolonged obstructed labor, based on a list drawn from the Maternal and Child Health Integrated Program Quality of Care Survey. Over 3/4 cite the 4 criteria at the top of the figure, and less than half of the respondents cite uterine tetany, temperature greater than 37.5 Celsius, and signs of shock. The survey looked at labor outcomes and asked respondents to select which ones may follow prolonged obstructed labor. The majority identify all the specified outcomes as potential consequences, with slightly fewer respondents selecting infection. Respondents from Africa were significantly more likely to cite infection, ruptured uterus, perinatal/birth asphyxia, and fistula as potential outcomes. The survey assessed how SBAs manage obstructed labor, listing practices from established criteria for auditing clinical quality of obstetric care. The majority report either always or sometimes utilizing the recommended practices for managing prolonged obstructed labor. While most recommended practices were done quite frequently, a notable number report never or only sometimes giving antibiotics, choosing the route of delivery based on degree of obstruction, and ensuring that delivery occurs within 2 hours of diagnosing obstructed labor. Respondents from Southeast Asia and non-public facilities were significantly more likely to always utilize many of the practices. The vast majority report utilizing urinary catheterization for patients who experience prolonged obstructed labor, and respondents from Southeast Asia were significantly more likely to report always doing so. Figure 6 illustrates the minimum and maximum number of days respondents report catheterizing prolonged obstructed labor patients. A considerable proportion report 1 day, followed by 7 days or 3 days for the minimum duration, and 7 days, 14, or 21 days for the maximum. Table 4 shows the median number of days respondents catheterize, with 3 being the minimum and 10 being the maximum. Disaggregating by region and facility type, we see that respondents from Southeast Asia and non-public facilities report longer durations of urinary catheterization, which may be indicative of bed space availability. In 2016, the Nigeria Ministry of Health issued the first national guideline on urethral catheterization for prevention and management of obstetric fistula, based on global recommendations and expert consultations. For those who utilize urinary catheterization following prolonged obstructed labor, the survey examined adherence to these guidelines. The vast majority report that they always retain the catheter and refer the patient if there is suspicion of fistula, as well as counsel patients at discharge. And the practice with the least adherence is performing pelvic examination prior to catheter removal. In addition to these practices, the survey examined respondents' opinions and beliefs about postpartum urinary catheterization for patients who experience prolonged obstructed labor, using statements derived from existing guidelines and curricula. The statement that solicits the most disagreement is about routine urethral catheterization for 14 days with a high fluid intake for those who survive prolonged obstructed labor. And the statement that solicits the most uncertainty is about the potential of early catheterization after prolonged obstructed labor to heal small fistulas. As sepsis is an important potential consequence of prolonged obstructed labor, the survey asked respondents about their practices related to antibiotic use across different stages of pregnancy and delivery. Table 7 provides the percentage of respondents who utilize various antibiotic practices. Antibiotics are most frequently utilized following preterm pre-labor rupture of membranes, for clinical signs of chorioamnionitis, with documented antenatal infection, and for prevention of infection. Antibiotics are least frequently utilized following uncomplicated vaginal births and following cord clamp at the time of cesarean section. Overall, respondents from urban and public facilities report higher usage of antibiotics across labor and delivery. Lastly, the survey inquired about access to supplies for urinary catheterization. 2/3 report that supplies are always available, and respondents from Southeast Asia and non-public facilities were significantly more likely to report that bladder care supplies are always available, which is consistent with the higher use of urinary catheterization following prolonged obstructed labor reported in Southeast Asia. The findings demonstrate notable differences by region, facility type, and geography. While in-service training was stronger and partograph usage was higher among those from Africa, respondents from Southeast Asia were more likely to report having relevant protocols in place, employing best practices for postpartum bladder care and management of prolonged obstructed labor, utilization of urinary catheterization following prolonged obstructed labor, and greater availability of bladder care supplies. Additionally, respondents from non-public facilities were stronger in terms of postpartum bladder care practices and urinary catheterization following prolonged obstructed labor, and had the advantage in terms of availability of appropriate protocols and supplies. Lastly, those in urban facilities were more likely to report employing best practices for postpartum bladder care and management of prolonged obstructed labor, and stronger usage of antibiotics across labor and delivery. Overall, the findings show that the majority of respondents report practicing many of the recommended best practices related to intrapartum and postpartum bladder care and management of prolonged obstructed labor. While there was some variation in how respondents defined prolonged obstructed labor, respondents had a strong understanding of the criteria used to identify it and its potential outcomes. Despite this, the survey reveals the lack of facility protocols in place for SBAs on providing intrapartum and postpartum bladder care and management of prolonged obstructed labor, as well as notable differences in in-service training, utilization of clinical practices, and availability of supplies between regions, facility types, and geography. One key limitation of the survey was that it was primarily administered online. Online surveys typically recruit respondents who have greater access to internet connectivity. Given the sample skew toward higher level facilities in urban areas, the analysis was not representative of the entire maternity context in low and middle income countries, and was specifically limited in its ability to describe practices employed at lower level facilities and in non-urban areas. Another limitation was the likely bias among respondents to report doing many of the recommended best practices. The survey was deliberately designed to only include recommended practices as to not unintentionally encourage SBAs to exercise harmful practices, and respondents were likely able to deduce this. The most notable example of this is, of course, the high reporting of partograph usage to monitor labor. While the analysis looked at variations by region, facility type, and geography, it would have also been useful to look at variation by health professional cadre. However, given the overwhelmingly large proportion of midwife respondents, such analysis was not possible. Expansion of this survey with a larger sample may yield more interesting findings.
Elly, thank you so much for that summary of this analysis, which really is extremely fresh and hot off the presses. And I want to note that for those who are interested in this topic, the full report of the survey and its findings will be on our website soon, and we encourage you to visit and grab a copy there. And of course, the archive of the webinar will be there soon as well. Now, before we turn to those of you joining us on the webinar and your questions, we are really fortunate to have with us Sheena Currie, who's a senior maternal health advisor at JPIGO and who has a wealth of experience looking at the contexts in which skilled birth attendants work in low and middle income countries and the things that affect their practice, their knowledge, et cetera. So we're really lucky that Sheena has joined us to give us her comments on these survey findings and to talk about some of their implications for programming and for policy as well. So we'll turn to Sheena.
Good morning and good afternoon, everyone. I'm joining you from Scotland, and thanks to Elly and Vandana for the opportunity to comment on some of the findings from this topical study. The findings revealed a very strong foundation for improvements and standardisation in intrapartum and postpartum bladder care, as well as the management of prolonged and obstructed labour. There is much to feel positive about in these findings of key clinical practices. For example, 73% of stillbirth attendants report always asking postpartum patients about problems with bowel or bladder function. This is quite high, as checking these functions after birth as part of routine postnatal care is a fairly new recommendation. Let's begin with highlighting the role that stillbirth attendants, and more specifically midwives, can play in supporting best practices in labour care. These include ensuring the woman in labour moves around, she uses non-supine positions, is supported with a birth companion, is well hydrated, has easy access to clean washrooms with water to encourage voiding, and especially she receives respectful care in that she is given full explanations and information, for example, on the importance of voiding regularly and why the providers would like to measure and test the urine. One of the practice recommendations noted that all women diagnosed with prolonged or obstructed labour should be catheterised prior to assisted vaginal delivery or caesarean section for a period of 14 days and put on a high fluid intake regime to prevent fistula formation needs consideration on flexible ways to provide this, especially given that 14% of the respondents disagree and 17% are not sure about this regime. I checked with one of my colleagues in Rwanda and she explained, "This doesn't require the woman to be an inpatient. If there is no other conditions that require her to stay in hospital, she can go home and come back for follow-up visits. She will also be provided information on when she can come back before the given appointment, such as when she feels she's developing fever, the urine is not flowing well through the catheter might be obstructed, etc. This flexibility and ability to adapt to women's wishes could improve the uptake of urinary catheterisation and improves partnership in care. Secondly, the analysis examining variations in practices by region, facility type and geography exposes areas where learning for support for stillbirth attendants as part of quality improvement can be strengthened to promote more widespread adoption of effective intrapartum and postpartum practices. While respondents from Africa and public facilities received more in-service training, it was respondents from South Asia and non-public facilities who utilised more of the recommended clinical practices. Pre-service education and in-service training for skilled attendants, particularly midwives and nurses within Africa and at public facilities, needs to emphasise best practices for intrapartum and postpartum bladder care, as well as the management of prolonged and obstructed labour, including competency-based training in catheter insertion and management according to standard. It's worth highlighting that training by itself may not affect behaviour change, so it's important to include post-training follow-up, such as through mentorship, and preferably as part of quality improvement activities. Checking for fistula is mentioned in the existing ICM essential midwifery competencies. These are being updated and are due out this year, and we expect prevention of fistula to be more prominent. It would actually be interesting to know how many countries have prevention of fistula in the pre-service curriculum, as it's essential. And thirdly, stillbirth attendants reported that urinary catheterisation after prolonged obstructed labour is feasible and acceptable, meaning that its systematic practice can be scaled up to prevent obstetric fistula in low resource settings, and we've already shared the example from Rwanda. Urinary catheterisation is not complicated, and the decision to catheterise must be the midwife's if she has clear criteria to guide her, especially when there are no medical doctors available. For example, when the duration of labour exceeds 18 hours. However, skilled attendants must be supported with facility protocols, quality in-service training, preferably on the job, and consistent availability of supplies, especially within Africa and at public facilities. It's important to not only ensure having up-to-date evidence-based protocols, but all staff need to be aware of these and consider how facilities can monitor compliance with protocols, e.g. clinical audits, as part of efforts to improve quality of care. As a quick update on prolonged and obstructed labour, the recently released WHO intrapartum care guidelines, including how to monitor the progress of labour, show a changing landscape, especially reuse of the partograph, and we await further updates on this. The new guidance does note that a standard duration of the latent first stage of labour has not been established and can vary widely from one woman to another. However, the duration of active first stage, which is now defined from 5 centimetres cervical dilatation until full dilatation, usually does not extend beyond 12 hours in first labours and beyond 10 hours in subsequent labours. So ensuring selected best practices are in use, as noted in the findings, can be context specific. For example, appropriate catheter use and care is a balance in efforts to reduce unnecessary interventions which may lead to infection and/or inappropriate use of antibiotics, which is increasingly a problem. So in summary, ensuring evidence-based clinical protocols are up to date, that all staff are aware of them, especially new staff, and systems for providers to consistently perform to standard are improved, will contribute to improved care. So I'll leave it there and hand back to Vandana and Elly, and happy to take questions. Thank you.
Sheena, thank you so much. Really appreciate your comments, Sheena. And I think also putting the findings on these specific practices in the broader context of evolving intrapartum care guidance, and also the very practical considerations that can help optimize the use of recommended best practices and help minimize longer-term consequences for women who've experienced prolonged and obstructed labor. So I want to remind you, we're taking questions through the GoToWebinar interface, and we have a question, which is that, and it's for Elly, and I'll read the question so everyone knows it, and then we'll turn to Elly. So it's about whether or not the survey collected information on indications for and practices related to intrapartum urinary catheterization for prolonged and obstructed labor. So not postpartum, but intrapartum. And we did ask questions about that, particularly referring to the guidance that was released in Nigeria, the National Ministry of Health guidance. So we're going to go back to the slide that looks at this, and Elly will take us through some of those findings.
So we're just going back to the slide that had to do with intrapartum bladder care. That is it. So on table 2, you can see we've outlined a number of practices related to intrapartum bladder care. Some have to do with catheterization during intrapartum period, and some do not. So I will read through some of the ones that have to do with catheterization during the intrapartum period. So for instance, the third practice on the table is, if necessary, catheterize using a Foley catheter before assisted delivery or cesarean section, and document and monitor urinary output. So you see that 93% report practicing this, 74 always, and 19 sometimes. And then as well, we have catheterized the laboring woman if the partograph action line is crossed. And here we have 55 reporting always and 33 reporting sometimes. And the last one is also very key in terms of urinary catheterization. So if urethral catheterization in labor is used, practice intermittent catheterization, as this reduces the risk of urinary tract infection. And we have 37% reporting always and 41% reporting sometimes. And that is also the practice with the highest number of respondents who report never practicing it at 21%.
Elly, thanks for taking us through those. And I know that these can be quite dense findings to hear and to sort of process in a rapid format like this. So I do encourage everyone to look at the report who's interested in the specifics of the indications and practices that are most common or least common. Elly, I want to ask you a question. You mentioned one of the primary limitations of this is that we're doing an online survey. You know, it was the best way to make it low cost, the best way to make it available rapidly all over the world. But we know that has a consequence. And, you know, it requires clinicians to have fairly consistent access to the internet and to have computers. And we know, for example, in Bangladesh, we found that a lot of the midwives at sites that we were working with simply didn't have laptops where they could take the survey. And I know that you worked with colleagues there to manage that concern. Since there is a bias, you know, not bias, but since this survey can't be representative of lower level facilities, of many of the places where midwives don't have internet access, what are your thoughts on how to get more broader information or more representative information for those other contexts? What do you suggest?
Thank you, Vandana. Thank you very much for that question. Yes, as Vandana mentioned, one of the key limitations on the survey was indeed the fact that we had a skew towards higher respondents from higher level facilities and urban areas. We first administered this survey online, as I mentioned, but we were finding that there was a real challenge and barrier to being a respondent to the survey in many lower for respondents from lower level facilities, and particularly in Bangladesh. And so we worked closely in Bangladesh with our colleagues there, our Fistula Care Plus colleagues in Bangladesh, who we developed a hard copy, a paper version of our survey instrument, and our colleague in Bangladesh went out to facilities that we partner with and whom we have a relationship with, both at that higher level, but as well as at maternity facilities. So we were able to have an additional, I believe it was around 50 respondents from Bangladesh who were not able to go online because of internet connectivity challenges and limitations, and were able to provide their responses on the hard copy survey. So to answer Vandana's questions about how can we better get a more representative sample and better understand what is happening at that at the maternity context at lower level facilities, one thing we are going to do as we publish this report on our website is we are going to make our instrument available to all, and we want to encourage people to replicate our survey so that we can generate broader and more representative findings as we move on.
Thanks, Elly. And absolutely, we want everyone to have access to these tools because they may be useful. And even if it's not the whole survey, elements, the most important questions, especially, for example, those who are working on supply chain management, if you're really trying to understand what the providers that you're supporting have access to. So modules of the survey might be more helpful for some settings than others. So I want to then turn to Sheena. We have a question coming from you. And it says, Sheena, I think I heard you mention use of postpartum indwelling or leg bag catheter for 7 to 14 days. Is this becoming more common? So we'll turn to Sheena to respond to that. Okay, unfortunately, we're having some connectivity problems and we can't hear Sheena. So I'm going to ask Sheena to relay her response to me on Skype and we will repeat it. So Sheena's saying yes to that question, that use of postpartum indwelling or leg bag catheter is becoming more common, and that increasing more flexible ways such as these approaches will improve compliance to the goal of catheterization after prolonged or obstructed labor. We are receiving a comment from Pandora Hartman, who's joined us, saying drip and open method, not leg bag. So I think what this reflects is that there are a variety of ways that catheterization can be approached and different methods that may be more appropriate for different settings, and that may enable catheterization to be, as Sheena had said earlier, provided through outpatient rather than inpatient approaches. So I think that we're just taking a look to see if we've had any more questions coming in. And I think that's it for now. So what we will do is very shortly after this, we'll put the archive of the webinar up on our website. And if anyone who's joined us does have any additional questions, please feel free to send them along to us, and we will be very happy to answer them on the website when we post about this report. And I think that in a few weeks, we will have the final report of the survey available online as well. And we encourage everyone to take a look at that. Thank you so much to everyone for joining us. And I want to just remind you again that we are at Fistula Care on Twitter, and it's fistulacare.org is the website. And before we close, I really want to thank USAID for their constant support of this work. And I want to thank all of the skilled birth attendants in low and middle income countries who took the time to share with us their knowledge, their practices related to this very important issue, because it's their practice and their contribution that enables us to learn about what is needed and where we can go next. So thank you everyone for joining us.